Geriatrician here. Welcome to Top Med Talk. It's a conference highlight, and it's taken from our coverage of Anaesthesia 2018, the international meeting of the Royal College of Anaesthetists. It was held at the British Museum, and the entire team was there recording conversations with the various speakers. This particular piece is taken from a conversation between Desiree, Chappell, Monty, Mythen, and Dr. Jugdeep Desai, clinical lead, POPs and consultant geriatrician at Guy's and St Thomas's NHS Trust. Have a little listen to this.
Top Med Talk.
Jugdeep here, and you are a geriatrician. And today you were talking about utilization of that profession on the multidisciplinary team. We're talking about perioperative surgical pathways and taking care of the elderly population. Can you give us a little bit about your background and what you're focused on?
Yeah, so I'm a clinical geriatrician working at Guy's and St Thomas's, which is a large teaching hospital in the middle of London, so just down the road from here. And I suppose the reason why we all got interested in perioperative medicine in particular was because we found that as geriatricians we were being called to surgical wards 3 or 4 weeks down the line from a surgical intervention, when the patient had run into a number of different complications, different specialists, different disciplines, all being involved along the pathway, but maybe each of those specialties really focusing very much on their area of expertise and not really taking the holistic view of what was happening from the patient's perspective and what they wanted to get out of that particular intervention. And so often when we were called, at that point patients had deteriorated, they weren't doing so well functionally, and we were often called to try to help with the rehabilitation and particularly the discharge planning. And not infrequently being asked to kind of take the patient away now because they were surgically fit. And so that really led us into thinking that patients needed a different approach, and really building on the work that you were saying, that it's very much about teamwork and the appropriate people being involved at the appropriate point throughout the surgical journey, but maybe having one team who are keeping oversight from the contemplation of surgery through to discharge and recovery at home or back in the community. And us feeling that maybe that was where we were adding value, that we could see people throughout that whole pathway and be working particularly with our other colleagues in therapy, dietitians, community pharmacists, back with primary care to coordinate that pathway of care. So certainly teamwork kind of being a big part of it.
Yeah, that's great. You were talking a little bit too about shared decision making and bringing the patient in really as part of that team as well, and how is that working for you?
Yeah, and I think that's probably something that actually has been very kind of embedded in geriatric medicine training kind of from the very beginning, really. That's something that we're all very used to doing. So although now we use the term such as shared decision making, actually that's been something that's been part of geriatric medicine kind of from when we all started practicing. So I think what's really important with shared decision making is the fact that it has to occur throughout the perioperative pathway. It's not one single decision that we're talking about. So there's the initial decision around contemplation for surgery and whether that's appropriate. Then there's the assessments and what needs to happen at each point in the assessment around the optimization, and then again reviewing the risks, benefits, potential harms of an intervention once you've optimized patients, and then again as the patient progresses through the journey, reviewing where we're at, what the patient wants to be achieving from that intervention, and us supporting the team to be able to deliver that if that's appropriate. And of course, you know, there's issues around patient choice, but we need to be providing options which are actually feasible and evidence-based.
Yeah.
That's a very fundamental question is, when do you become geriatric?
Yeah.
Is it a state of mind and body, or is it an age cut-off these days?
So there's two schools of thoughts amongst geriatricians. Some kind of have very much worked on age-based cut-offs, and that's progressed, kind of become progressively older. as the demographics have changed. And so some units around the country operate on a 75 plus kind of model, others even say 80 plus. In other units, such as ours, we actually base it on multi-morbidity and geriatric syndromes. So we'll see patients in their 50s who have that degree of multi-morbidity, frailty, cognitive impairment, lifestyle issues that actually biologically are putting them into the same category as the chronologically older population.
Wow, that's it. So the POPS clinic, you said that you were the lead for that. Can you explain what that is?
Yeah, so it's proactive care for older people undergoing surgery. It's a clinic where we see complex, generally older patients, but we do see people in their 50s. We see patients who are having specific procedures, so all upper GI surgery above the age of 75, all complex AAAs above the age of 60, but then other patients referred to us on the basis of frailty, multi-morbidity, geriatric syndromes.
Top Med Talk.
That piece was taken from a longer conversation to be found under the title RCoA 6, Geriatric Care and the Value of Teamwork. Put that into the search engine on topmedtalk.com and you'll find the entire piece waiting for you to listen to it. topmedtalk.com. Do remember you can meet the Top Med Talk team when we're going to be at the results of the Extreme Everest Symposium, June the 14th, live from Duke University in America. And of course, we're at all of the EBPOM meetings. Check out ebpom.org and find out how you can meet the Top Med Talk team.